in the last week, I hope you have seen, we have discussed about the relations of the pancreas. I have started with the relations of the pancreas, and this week you have seen the specimen of pancreas, right? Everyone, I hope you have seen the specimen of pancreas. Now, along with the specimen, have you seen the surfaces, borders? Have you seen the surface? Okay, so along with the specimen, I hope you have seen the surfaces, borders, along with that the relations of the pancreas, right? Now, can anyone tell me what are the parts of the pancreas? First is the head. From head there is a process that is called uncinate process. Next is the neck, constricted part, that is the neck of the pancreas. Okay. Now, can you tell me if is there any demarcation between the head and the neck? By looking at the pancreas, specimen of the pancreas, can you tell me any demarcation or any demarcating line which separates the head and the neck of the pancreas? Think, you have seen the specimen. That demarcation is present posteriorly. Yes, so there is a groove. Okay, in that groove you can see the trunk of the portal vein. Okay, so the groove where it is situated, the trunk of the portal vein, that particular part will be the neck of the pancreas. Okay, so after neck, the constricted part, next is the body of the pancreas, followed by the tail of the pancreas. Right now, if you have seen the specimen of the pancreas, have you noticed there is a projection from the proximal part of the body, that also from the superior aspect, from the upper border? Have you noticed? Anyone? Yes. No. Uncinate process is present in the head. Now, if you have seen the specimen carefully, I hope you have noticed that on the proximal aspect of the upper border of the body, a elevation is there. Yes, that is called as tuber-omental. Okay, tuber-omental. The tuber-omental is present, and that is a very important landmark. Okay, because if tuber-omental is there, that means it is the body of the pancreas. Next, tuber-omental is related to which part, which structure? It is related to celiac trunk. The tuber-omental is related to celiac trunk. Very important landmark. Okay, so like this, there are few things which you should have seen in the specimen. I don't know whether you have seen or not. Okay, when the specimen is in situ, that means when it is in the body. Okay, whenever it is lying on the posterior abdominal wall, at that time you should have seen all those structure. Okay. Anyway, today also you are having time. Whenever you will go to the dissection hall, I will request everyone to see all the relations of the pancreas. Okay. So in the last class we have discussed about the relations of the head of the pancreas along with the uncinate process. Okay. After that, the next part is the neck of the pancreas. So as I said, neck is a slightly constricted part, and it will connect the head to the body. If you see the length, it is approximately 2.5 centimeter, and if you see the direction of the neck, it is directed forward, upward, and to the left. Okay, forward, upward, and to the left. That is the direction of the neck. Okay. Now, in the external features of the neck, it is having two surfaces and two borders. Okay, very simple. What are the surfaces? Anterior surface, and there will be posterior surface, and two borders, superior border and inferior border. Okay, these are the parts of the neck. If you see the anterior surface, so the stomach will be there, that is the pylorus of the stomach. Posteriorly, what will present? That will be the commencement or the beginning of the portal vein, which already we have discussed in the portal vein chapter. Okay. Now, upper border, if you see, it is related to the first part of the duodenum, and inferior border, it will be related to the root of transverse mesocolon. Now, if you see the diagram, okay. Now, in this diagram, these are the relations of the anterior and the posterior surfaces. Okay, anteriorly, as you can see, the pylorus of the stomach is related. Posteriorly, the commencement of the portal vein is taking place. Okay, which you can see in the diagram. Okay, next, if you see the superior border, so this is the neck region, this is the neck region. So you see the superior border is related to the first part of the duodenum, and inferior one is related to the root of mesentery. Okay, root of transverse mesocolon, not mesentery, root of transverse mesocolon. Okay, so this is the inferior relation. Okay, next is the body of the pancreas. I hope you have seen the body. Now, body of the pancreas is a elongated structure. Okay, it extends from the neck to tail. Okay, and if you see the direction, it is passing towards the left, slight upwards and backward inclination. Okay, it is also going towards the left, but slightly upward and backward inclination. This is how the body of the pancreas is oriented. Okay, now this particular body of the pancreas is prismoid in shape. Okay, if you directly see the body, it is prismoid in shape, and after that, if you take the cut section, if you take the TS of the body, then it will appear triangular shaped. Okay, it is appearing triangular in nature. Next, in case of body, 3 borders and 3 surfaces are there. Okay, so prismoid shape, I hope you know what is prism shape, right? Prism already you have seen. तो जो body होता है, that is a prismoid shape. Now from prismoid shape, if you take a cut section, if you take a TS, then it will appear triangular shape. Okay, now this is very important so that you can understand the surfaces and borders, because based on that you have to know about the relation. Okay, now here you can see the triangular shaped cut section of the body. Okay, you can see the superior border, you can see the inferior border, and you can see the interior border. Okay, next you can see the surfaces. This is the anterior surface, posterior surface, and inferior surface. Okay, so please study accordingly so that you can understand about the surfaces and borders, especially in case of the body. Okay, I know the confusion takes place in the body of the pancreas, because in bones you have studied those surfaces and borders. Okay, but here the surfaces and borders exactly like bones will not be there. Okay, so you could take the examples of this type of diagram to understand the surfaces and borders. Okay, so 3 borders, 3 surfaces are there. Okay, so first we'll see about the borders. So the anterior border, okay, anterior border will provide the attachment to the root of transverse mesocolon, okay, which is the peritoneal fold of the transverse colon. Next, superior border, okay, superior border is related to celiac trunk. Now this particular part is very important. In case of body of the pancreas, okay, the superior border, proximal part of the superior border, a elevation is there, that is called as tuberomental. Okay, as you can see, that is called tuberomental. Now this tuberomental, which is extending from the superior border of the proximal part of the body, okay, it is extending up to the lesser curvature, lower part of the lesser curvature of the stomach, and it is present in between the layers of the lesser omentum. Okay, now this is an important landmark. This is an important landmark. Why? Because from there you can identify whether it is body or it is the neck of the pancreas. Next, this particular tuberomental is related to a very important structure that is called celiac trunk. Okay, you have studied the celiac trunk, you have seen the celiac trunk. Okay, so in case of the borders of the pancreas, I have shown you the cut section. Okay, now three borders are there. What are those borders? Anterior border, superior border, and inferior border. Okay, now we were discussing about the superior border. Now there is a very important part which is related to the superior border, that is the tuberomental. Okay, now tuberomental is related to the celiac trunk. Okay, and as I say, tuberomental is a important landmark. From there you can know whether it is the body or the neck of the pancreas. After that, tuberomental is related to the celiac trunk. Okay, and from there if you go to the right side, then it is related to the hepatic artery, and if you go to the left side, then it is related to the tortuous splenic artery. Okay, so it is an important landmark, the tuberomental. Next, if you see the inferior border, okay, it is mainly related to the superior mesenteric vessels on the right side. Now here you can see the diagram. Okay, in this diagram, so this particular part is the body. Okay, now body is having, this is the superior border. Okay, now this is the inferior border. See, this is the inferior border, and this particular part is the anterior border. Okay, now in the anterior border you can see it is giving attachment to the root of transverse mesocolon. Now from the superior border on the proximal part, see a elevation is there. This is called the tuberomental. Okay, I hope you can see the diagram, this particular part. Now this is related to the celiac trunk. Okay, now this particular celiac trunk, the arteries which are arising, the branches which are arising, on the left side we are getting the splenic artery, which will be tortuous in nature, and on the right side we are getting the hepatic artery. Okay, so this is a very important relation for the superior border, proximal part of the body of the pancreas. Next, inferiorly on the right side, the superior mesenteric vessels. Okay, the relation are superior mesenteric vessels, that means artery as well as vein. Next, three surfaces are there. Okay, so what are the three surfaces? Anterior surface, posterior surface, and inferior surface. Okay, three surfaces are there. Now on the anterior surface, what do you think, what will be present? First of all, it is concave, and it is covered by peritoneum, though pancreas is a retroperitoneal organ, and it is related to lesser sac and the stomach. I hope you have studied greater sac and lesser sac. In peritoneum you have studied greater sac and lesser sac, right? So this particular part is related to the lesser sac and then stomach. When you have studied the stomach, I hope you have studied about the stomach bed. So pancreas is a structure of the stomach bed, if you remember. Okay, so that is the anterior relation. Now posteriorly, if you see the pancreas, it is devoid of peritoneum, that means it is not covered by the peritoneum. Okay, though it is present horizontally, that's why it is covering most of few of the organs. Now here you can see, this is a beautiful diagram. Now this is the outline of the body of the pancreas. This is the tuberomental. So you can see the structures which are situated posterior to the pancreas, though it is situated, it is lying horizontally. Now first of all, you can see the aorta is there. Okay, then left crus of the diaphragm, left sympathetic chain, then you can see left kidney, left ureter, left suprarenal gland. Okay, so these are the structures which are situated behind the body of the pancreas. Okay, so this will be the posterior relation of the body of the pancreas. Okay, so whenever you are picking the diagram, as I said, for relation, diagrams are very important. Okay, now if I ask you the posterior relations of the pancreas, by looking at the diagram you can answer, right? So that's why whenever you are picking the diagram, pick it in such a way that it can give the answer. Okay, and this is a schematic diagram only. The diagram which I have shown over here, this is a schematic diagram, means drawable diagram. You can draw during the time of exam. Okay. Next, lastly is the inferior surface. So see, the inferior surface, what is present on the inferior surface? First of all, the inferior surface is covered by peritoneum and it is related to duodenojejunal flexor. Okay, so see, this is the inferior surface. So here the duodenojejunal flexor is present. Okay, along with that, it is also related to the jejunum. Okay, and left colic flexor. Coils of the jejunum, left colic flexor. Okay, these are the structures which are present inferior to the pancreas. Okay, inferior surface of the pancreas. So these are the relations of the body of the pancreas, where we have seen three borders and three surfaces are there. Next is the tail of the pancreas. Okay. Now, if you see the tail of the pancreas, it is a narrow left extremity of the pancreas. Narrow left extremity of the pancreas. Where it is situated? It is situated inside the lienorenal ligament along with the splenic vessel. It is situated inside the lienorenal ligament along with the splenic vessels. Okay. Now it comes in contact with the lower part of the gastric surface of the spleen. That means it is extending up to the spleen. You have studied the spleen, you know the surfaces of the spleen. Okay. Now the most important aspect of the tail of the pancreas is most of the islets, okay, or islets of Langerhans are present inside the tail of the pancreas. Okay. Now these are related to the visceral surface of the spleen in between the gastric impression and the colic impression. These are the areas of the spleen where exactly the tail of the pancreas is situated. And do you remember in the last class I have mentioned a very important clinical significance? During the splenectomy, though the tail of the pancreas is reaching up to the gastric surface of the spleen, so the damage can take place of the pancreas, tail of the pancreas. And as I said, in the tail of the pancreas, most number of islets are present. So if that particular part get damaged, patient will suffer from diabetes mellitus. Okay. Next, ducts of the pancreas. Now, why ducts are important? Have you seen the ducts in the pancreas, in the specimen of the pancreas? Have you seen the duct? Anyone? In the specimen of the pancreas, have you seen the ducts? No. So today when you will go to the dissection hall, try to see the ducts of the pancreas. Very important. Okay. Now, what do you think? Why these ducts are important? Why these ducts are important? See, pancreas is a exo and endocrine gland. Means exocrine part is also there, endocrine part is also there. So exocrine part is producing pancreatic juice where the enzymes are there. It has to be carried. How it will be carried? It is carried by the ducts of the pancreas. And it is carried from the pancreas to the second part of the duodenum. Okay, that's why ducts are important. Okay, so mainly two ducts are there, main pancreatic duct and accessory pancreatic duct. Okay. Main pancreatic duct and accessory pancreatic duct, two ducts are there. Now, if you see the main pancreatic duct, it is also called a duct of Wirsung. From where it is starting? It is starting from the tail of the pancreas and traversing whole length of the pancreas. Okay. Next, when that particular duct comes to the neck, okay, it turns downwards and then to the right and then enter the second part of the duodenum. Now, while it is entering the second part of the duodenum, it will join by the common bile duct to form hepatopancreatic ampulla or ampulla of Vater, and then it will open into the second part of the duodenum. Okay. Now, the major duodenal papilla, which is situated, that is 8 to 10 centimeter distal to the pylorus of the stomach. Next, now the duct from the tail up to the neck, it is traveling. Okay. Now, in that particular distance, it is received by smaller ducts. Okay, it is received by smaller ducts in right angle. So smaller ducts will come and join the main pancreatic duct in right angle. And if you see the structure, it is herringbone pattern. The structure is herringbone pattern. I'll give an example. I hope you have seen small fish. Whenever you are eating the small fish, after removing the flesh, have you seen the skeleton of the fish? So I'm talking about small fishes. Okay. So at that time, have you seen the skeleton, structure of the skeleton? One bone is there and other bones are attaching into it. That is the herringbone pattern. Okay. Now here you can see the ducts of the pancreas. Okay. So this is the main pancreatic duct or duct of Wirsung. To see, it is starting at the tail of the pancreas. When it is coming towards the neck, it is going downwards. Okay. And then it enters into the second part of the duodenum. Okay. Now when it is entering, it is accompanied by the common bile duct to form the hepatopancreatic ampulla of Vater, and then it will drain into the major duodenal papilla, which is situated on the posterior medial wall of the second part of the duodenum. Already we have discussed and several times I have mentioned this. Now can you see the smaller ducts? See the smaller ducts. So these smaller ducts will join the main pancreatic duct. After that, the structure which is appearing, that is called as herringbone pattern. Okay. Next, you can see a smaller duct which is beginning from the lower part of the head of the pancreas. Okay. After that, it is going upwards and crossing the main pancreatic duct, and then draining into the second part of the duodenum into the minor duodenal papilla. Okay. That is the accessory pancreatic duct. In some cases, accessory pancreatic duct is absent. Okay. But in some cases, it is present. Now, the main pancreatic duct, just near the termination, a sphincter is present. Okay, that is called as sphincter pancreaticus. The main pancreatic duct, before termination, a sphincter is present, which will control the flow of the pancreatic juice through that duct, and that is called sphincter pancreaticus. Okay. So that is all about the pancreas. Next, the blood supply of the pancreas. So what do you think, what will be the blood supply of the pancreas? The main source of the blood for the pancreas is the splenic artery. Okay, someone may think it is pancreaticoduodenal arteries. No, it is not pancreaticoduodenal arteries. Okay, it is splenic artery. Okay. Superior and inferior pancreaticoduodenal arteries are there. Already we have discussed in the blood supply of duodenum. They are also supplying the pancreas, but only the head and the neck of the pancreas. Remaining body, tail, entire part is supplied by the branches of splenic artery. Okay. So splenic artery, we know that it is a branch of celiac trunk. It is mainly supplying the blood to the most of the pancreas. Now the branches are supplying the body and the tail of the pancreas. Now the branches which are supplying the body and tail of the pancreas, among them one artery is larger as compared to the other one, and it is called as arteria pancreatica magna. Okay, it is called as arteria pancreatica magna, which arises near the tail and run towards the neck of the pancreas. Okay, so this is one of the largest branch, okay, which is supplying the pancreas, that is arteria pancreatica magna. Now another branch is there which is relatively small, okay, and that is called as poda pancreatica. It is called as poda pancreatica. Next, superior and inferior pancreaticoduodenal arteries are also there, okay, which will anastomose. Where they will anastomose? Do you remember? Do you remember this diagram? In the blood supply of duodenum, we have discussed, I have shown you this diagram. At that time, I have told you that same thing will repeat in case of blood supply of pancreas. Okay. Now, though you have seen the specimen of the pancreas, okay, at that time, have you seen this particular blood vessel? Anyone? If not, then please go and see these blood vessels. These blood vessels are also present. When you have seen the specimen of the pancreas, at that time the duodenum was also there. Yes, duodenum was there. Okay, so I know the duodenum will be there. So in that, entire branches or all the arteries might not be there, but you can see some part of this particular arteries. Okay, I want that you should see how the branching pattern is taking place, okay, in the specimen, so that you can understand. So the superior and inferior pancreaticoduodenal artery, where they are anastomosing into the second part of the duodenum, C-shaped loop of the second part of the duodenum. Okay. Now before anastomosing, they are giving anterior branch and posterior branch, both the arteries. Okay, and after that they anastomose. And from there, as I said, arterial arcades will appear. From arterial arcade, straight branch will appear. Those are called as vasa recta. And then it will go and supply the structure. It will go and supply the organ. Okay, so all those things you should see in the dissection hall. Then only you can understand. So I hope you can see the splenic artery, the branches of the splenic artery. Then you can see the branches which are coming and supplying. Okay, you can see the arteria pancreatica magna. Okay, see arteria pancreatica magna. Then this superior and inferior pancreaticoduodenal artery, the anastomosis, the branches, and then they are supplying the pancreas, as well as they will supply the duodenum also. Okay. Next, in case of venous drainage. In case of venous drainage, if you see the superior, inferior Mainly the pancreas is drained by portal vein, superior mesenteric vein and the splenic vein. Okay, so first it will go to the splenic vein, superior mesenteric vein, followed by the blood will go to the portal vein. Okay. Next, lymphatic drainage for the head and neck, it is different, body and tail it is different, as you can see in the slide. In case of head and neck, it is draining into the ventral and dorsal group of pancreaticoduodenal lymph nodes. For body and tail, it is going to the pancreatico-splenic lymph nodes. Okay. From there, the efferents which are coming, they will terminate into the celiac and superior mesenteric group of lymph nodes. Okay. This is how the lymphatic drainage of the pancreas is taking place. Now, lymphatic drainage is also important because the carcinoma of the pancreas can spread through the venous route as well as through the lymphatic route. Okay, and then it can spread into the various parts. For example, it can spread into the liver, it can spread into the bone marrow, etc. Okay. Okay, next is the nerve supply. So in nerve supply, as I said, same, it will be divided into two parts. What are they? Sympathetic and parasympathetic. Okay, so as you can see, sympathetic and parasympathetic fibers. Now the sympathetic parasympathetic fibers will reach the gland or will reach the structure along with the branches of the arteries. Okay, in most of the cases, the nerve supply is reaching the organ or reaching the target along with the branches of the arteries. Now the sympathetic, what is the function of the sympathetic? It is vasomotor, whereas parasympathetic controls the pancreatic secretion. That also the exocrine part, not the endocrine part. Okay, two parts are there, exocrine part and the endocrine part. So exocrine part, not completely, partly it is controlled by the parasympathetic one. And what about the endocrine part? How it is controlled? Any idea? It is under hormonal control, which is secreted from the pituitary gland. Now, if you see the secretion, as I said, partly it is controlled by the parasympathetic division and partly by the hormones. Okay, for example, pancreozymin, cholecystokinin, which are produced from duodenal epithelium or duodenal mucosa. Okay, like this, the secretions are controlled, not entirely by the parasympathetic one. Okay, so whenever you are writing in the exam, don't mention that entire secretion, okay, is controlled by the parasympathetic one. No, it is partly. Next, the pancreatic juice, you know, that contains various enzymes, and what is the function of those enzymes? Completes the digestion. So, what about the sympathetic nerve supply, from where it is coming? Now if you see the sympathetic nerve supply, it is coming from T6 to T10 segment of the spinal cord for pancreas. Okay, and it is distributed to the pancreas via sympathetic contribution from the celiac plexus. Okay, so celiac plexus is one of the largest autonomic plexuses which are present in the posterior abdominal wall. Now the postganglionic fibers are distributed to the gland via arterial supply. Okay, through the arterial supply the branches will go and spread into the organ. The parasympathetic supply is coming from the posterior vagus nerve. Okay, now this is also coming through the celiac plexus. The exocrine lobules are innervated by fine network of parasympathetic and sympathetic fibers. Okay, next, sensory fibers. That means whenever there will be inflammation, at that time pain will be felt. Okay, now this particular pain can be pain sensation travels through both sympathetic as well as parasympathetic nervous system. Okay, now the pain arising from the gland may carry the sensory information in chronic inflammation. Okay, during the time of tumor or thermal chemical ablation of the celiac plexus is required. Okay, that means the celiac plexus is carrying both sympathetic and parasympathetic system, which is helping in carrying the pain sensation. So whenever there is pain from the tumor or other condition, at that time what happened? The ablation of the celiac plexus is done, okay, in order to reduce the pain. Innervation of the endocrine part is mainly by the parasympathetic division. Okay, endocrine part. Okay, so two parts are there, exocrine and endocrine part. Mainly the parasympathetic division is controlling the endocrine part. Okay, now while supplying the endocrine part, a plexus is formed around the islets, and that is called as neuroinsular complex. Okay, and that neuroinsular complex, the structure that we'll study in histology of the pancreas. Okay, that means the islets which are there, around the islets a plexus is formed, that is called neuroinsular plexus, and then it is supplying the islets. Okay, so though it is a histological part, so that's why I have not included over here, that we'll discuss separately in histology class. Now, I hope you remember several times I have mentioned about the celiac plexus, right? While explaining about the nerve supply, okay? But I have not shown till now about the celiac plexus. But I have mentioned that these are the autonomic plexuses which are situated on the posterior abdominal wall. Okay? Now, here you can see the diagram. Okay? Now, if you see the diagram, you can see the celiac plexus, you can see the superior mesenteric plexus, you can see the inferior mesenteric plexus. Okay, so mainly they are formed by both the division, that means sympathetic as well as parasympathetic division. Okay, for sympathetic division, mainly the lateral horns of the thoracic segment of the spinal cord, the fibers are coming. Okay, and for parasympathetic division, it is completely depend on the vagus nerve. Okay, as you can see in the diagram. So they will pierce the diaphragm. Okay, they will come and then they will form a plexus. Okay, now here you can see the ganglion is also formed, celiac ganglion. Okay, one of the largest in the posterior abdominal wall. Okay, so from there the fibers which are coming out, they will go and supply the organ. Now most of the cases they are formed around the blood vessel. If celiac plexus, it will form around the celiac artery. Why? So that the branches of that particular artery, when it is traveling towards the organ, these nerves can also travel along with the arteries and can reach the organ to supply that particular organ. Okay. Further details, as I said, we'll discuss in the nervous system chapter. Okay. Next, lastly, the applied anatomy of the pancreas. Okay. Now, in applied anatomy of the pancreas, do you remember the gallstone or the stone of the gallbladder which can obstruct the biliary system, extrahepatic biliary system that we have studied? Okay. Now, when the gallstone is obstructing the terminal part of the common bile duct, okay, terminal part of the common bile duct, at that time what happened? The bile is unable to flow into the second part of the duodenum. In that case, the bile can go back into the pancreatic duct. It can enter the pancreatic duct. Why? Because the sphincter which is present at the terminal part of the pancreatic duct is not strong, it is weaker. In that case, what will happen? There will be inflammation in the pancreas. Okay, there will be severe pain in the pancreas. Now, in that case, if any accessory pancreatic duct connects the main pancreatic duct and opens into the duodenum, it can compensate for the obstructed main pancreatic duct. Okay. Now, because of that particular stone, gallbladder stone into the common bile duct, the pancreatic duct can also be obstructed if it is present at the terminal part of the common bile duct, if the gallstone. Okay. Okay. Next, pancreatectomy. Pancreatectomy means the removal of the pancreas. Do you think is it possible to remove the entire pancreas? Anyone? Is it possible to remove the entire pancreas? No, it is not possible to remove the entire pancreas. Okay. So during some problem, for example, chronic pancreatitis, okay, some part or some portion of the pancreas may be removed, and that is called as pancreatectomy. Now, anatomical relation, blood supply, okay, relation of the head of the pancreas with the duodenum, it makes it impossible to remove the entire pancreas. However, some portion of the pancreas can be removed. Now, next is the acute pancreatitis, that is the acute inflammation of the pancreas. Now, when it occurs, mainly it occurs during the obstruction in the pancreatic duct. So, pancreatic duct is there. If it gets obstructed, at that time there may be inflammation, ingestion of the alcohol. Next, viral infection, for example, mumps, trauma. These are some causes of the acute pancreatitis. Now, whenever the acute pancreatitis takes place, it causes serious condition because the enzyme can leak from the ducts. If suppose blockage is there in the duct, okay, then what will happen? Continuous production of the enzyme will take place. Okay, as a result, the pressure in the duct will increase. Sometimes the duct may rupture also. If the duct ruptures at that time, what will happen? The pancreatic enzyme will come out, okay, and it will start autodigestion of the gland. Okay, it will start autodigestion of the gland. At that time, it is very painful for the patient. Now, clinically, it present severe pain. Now, where the pain will be felt? In the epigastric region. The pain will be felt in the epigastric region, radiating towards the back. Okay, first the pain will felt in the epigastric region, and from there it will be radiating towards the back. Along with that, fever, nausea, vomiting will also be there. Okay, now when acute pancreatitis is there, at that time, if you check the serum amylase level, it will be elevated approximately 3 to 4 times than its normal range. This is how the acute pancreatitis can be diagnosed. Next, there are other imaging modality by which we can diagnose the acute pancreatitis. For example, CT scan is there, MRI, ultrasound, easily it can be diagnosed. Now here I have added one CT scan image of the abdomen, contrast enhanced CT scan image of the abdomen. Can you see the pancreas? So this is how the acute pancreatitis appear when the CT scan is done. Okay, where you can see the size of the pancreas has been enlarged. Okay, and there will be some changes in the normal tissue density, and along with that, here you can see the necrosis also. Okay, so these are some identification which can be seen particularly in this image. Okay. Next, rupture of the pancreas. So generally, can you palpate the pancreas? Anyone in a living being? Is it possible? No, you can't palpate the pancreas. It is well protected on the posterior abdominal wall. Okay, and during the injury in the abdomen, generally pancreas doesn't rupture. But in a severe automobile accident, road traffic accident, okay, the pancreas can be damaged. Now, because of the pancreas is lying transversely, okay, just in front of the vertebral column, so the traumatic force, okay, which is applied forcefully, that can cause a damage to the friable pancreas. Now, rupture of the pancreas frequently tears the duct system. So, whenever there will be any trauma directly into the pancreas, okay, during the automobile accident, at that time what will happen? The duct system will get damaged. As a result, what will happen? The pancreatic juice will come out, okay, into the parenchyma of the pancreas and the adjacent tissues. So that will cause autodigestion of the organ, and that is severely painful or extremely painful. Okay. Next is the pancreatic cancer. So cancer involving the head of the pancreas account most of the extrahepatic obstruction. That means whenever there will be cancer in the head of the pancreas, at that time what will happen? In the last class I have shown you the diagram. It will obstruct the common bile duct. Okay, as a result, the patient will suffer from obstructive jaundice. Now, because of the posterior relation of the pancreas, cancer can also compress the bile duct, okay, and the hepatopancreatic ampulla. Next, when the cancer will be there in the pancreas, at that time patient will suffer from severe back pain. Okay, cancer in the neck and the body of the pancreas can cause vena cava obstruction, because the pancreas is overlying this large vein. It means if the cancer is there on the body or the neck of the pancreas, at that time it can compress the structure which are situated posterior to it. As a result, there will be compression in the vena cava. Now, there are various stages of pancreas cancer, okay, 0 to 5, okay. In that, stage 4 is the metastatic one, where the metastasis is taking place with the help of the lymph nodes and with the help of the venous drainage, okay. Now, in case of stage 4, pancreatic cancer spread into the other part of the body, such as liver, lung and peritoneal cavity, where different organs are situated, okay. So, in case of stage 4, pancreatic cancer is also called as metastatic pancreatic cancer, okay, and the cell travel through the lymphatic system, blood into the other part of the body. Okay, as you can see, in case of stage 4, from the pancreas, the cancer can travel into the various part, mainly with the help of the blood supply and with the help of the lymphatic system. Okay. So that is all about the pancreas. So we have discussed almost everything. Only the histology part of the pancreas is left. That we'll discuss in the next week. Okay. 1:30.
What's the 135?
35.
Should be 35.
35. Okay, so I hope you have studied about the liver. Everyone? Yes, you have seen the specimen of the liver. Okay. So today we will not discuss about the gross structure of the liver. Okay. Instead of that, directly I will go to the applied anatomy of the liver. I hope that one you have not studied till now. Okay, so today we will discuss, and if you see the list, it is huge. Okay, in case of the applied anatomy of liver, the list is huge. Okay, so we'll be discussing the important one. Okay, so first will be the palpation of the liver. So what do you think, how you can palpate the liver? Anyone? Just see the diagram. See where the hands are placed. Now is it possible to palpate the entire liver? No, it is not possible. Only the inferior border, okay, of the liver can be palpated. Okay, but whenever it is enlarged during the hepatomegaly, at that time it can be palpated. But in normal case, only the inferior border can be palpated. Now, how the palpation of the liver is done? Okay. Now, on the method of palpating the liver is to place left hand posteriorly behind the lower rib cage. That also right lower rib cage, one hand, and put the right hand on the person's right upper quadrant. Okay, lateral to the rectus abdominis muscle. Okay, then the person is asked to take deep breath, and the examiner will press posterior superiorly with the right hand and pulls anteriorly with the left hand. Okay, like this you can palpate that also the inferior border of the liver only. Okay, so this is how the palpation, manual palpation of the liver can be done. Okay, next is the hepatomegaly. Now, what is the meaning of hepatomegaly? Enlargement of the liver. Okay, now there are different causes of the enlargement of the liver. Okay, but what exactly happens means, if there is, we know that liver is a highly vascular organ. Okay, so if there is any rise in the intravenous pressure, central venous pressure, any rise in the central venous pressure, that will be directly transmitted to the liver. Okay, as a result, what will happen? It will become enlarged and it becomes engorged with the blood. That means if there is increase in the central venous pressure, okay, for example, increase in the pressure in the IVC, SVC, okay, at that time what will happen? It will be delivered to the liver, and as a result, enlargement is taking place. Along with that, engorgement with blood is also taking place. Now, the temporary engorgement stretches the fibrous capsule. Okay, when the engorgement is temporary, it will stretch the fibrous capsule of the liver, producing pain around the lower ribs, particularly in the right hypochondrium. Okay, in this case, the pain will felt in the right hypochondrium. Next, in addition, the disease produce hepatic engorgement such as congestive heart failure, bacterial viral diseases such as hepatitis also causes hepatomegaly. Okay, that means bacterial infection, viral infection, congestive heart failure, that can also cause hepatomegaly. Now, when the liver is massively enlarged, its inferior edge may be readily palpated. Okay, means easily you can palpate when the liver is massively enlarged. Okay, in some cases it can reach up to the right lower quadrant of the abdomen. Okay, next, tumors also enlarge the liver, which is a common site for metastasis. Okay, that means metastasis which is taking place from the other parts or the other organs into the liver, that can also cause hepatomegaly. Okay, now here you can see the enlargement of the liver: mild enlargement, moderate enlargement, and severe enlargement. And as I said, during the time of severe enlargement, it can reach up to the lower quadrant of the abdomen. Okay, in that case, the lower border of the liver can easily be palpated. Next, this is a CT scan image where you can see the enlarged liver, okay, where mainly it can be diagnosed with the help of craniocaudal length. In case of hepatomegaly, the craniocaudal length increases. Can you see the liver? This is the enlarged liver. Okay, this is also a CT scan image of the abdomen. Okay, where easily we can see the hepatomegaly has taken place. And in this case, the splenomegaly has also taken place. See, the size of the spleen has also enlarged. Okay. So nowadays it is very easy to diagnose the hepatomegaly. Okay, next is Pringle maneuver. Anyone, have you heard about this Pringle maneuver? Okay, now we know that liver is a highly vascular organ. Okay, so if there is any bleeding from the liver, in order to stop that bleeding, what is done? Can you see what is done? So we know that the lesser omentum which is there, two parts are there, you can see, of the lesser omentum. The one part which is attaching into the lesser curvature of the stomach, and you can see one part which is attached into the first few centimeter of the duodenum. Okay. Now in this particular part of the lesser omentum, what is present? You can see bile duct is there, portal vein is there, and along with that hepatic artery is also there. So it is clamped. Okay. So once it is clamped, then if any bleeding is, because these are the main source of blood supply to the liver. So if it is clamped, then what will happen? The blood supply to the liver will get stopped. Okay, as at that time the doctor can see what is the exact reason of the bleeding from the liver. After that also, if bleeding is taking place, that means problem is there in the IVC. Okay, and this clamp can only be kept up to 10 to 15 minutes, not more than that. Okay, because see, whenever you are clamping, okay, you are clamping the common bile duct, portal vein, hepatic artery. Okay, so it can cause necrosis in the liver. It can cause less blood supply in the liver. It can cause obstruction in the common bile duct. Okay, so numerous complications can take place. That's why only 10 to 15 minutes. Within that, the doctor has to find out why the bleeding has taking place from the liver. That is called as Pringle maneuver. Okay, next is the cirrhosis of the liver. Okay, now what happens in the liver cirrhosis? Anyone, have you heard about the liver cirrhosis? क्या होता है liver cirrhosis में? So you have to understand the concept. Okay, don't think that every time person consuming alcohol will suffer from liver cirrhosis. No, non-alcoholic liver cirrhosis is also there. Yes. So we know that liver is a primary site for detoxification of the substance which are absorbed from the digestive system. Okay, so whatever you are eating, doesn't matter. Whatever you are eating, it has to go to the liver. No other way. Okay, after that the metabolism will take place. So whenever we are eating anything, toxic substance may be present in that. Okay, and it has to be filtered, it has to be taken care of. So that is done by the liver. So as a result, it is vulnerable to cellular damage. In doing that, it is vulnerable to cellular damage. That means damage to the hepatocytes of the liver. Okay, as a result, what will happen? There will be consequent scarring. Scar formation will be there, accompanied by regenerative nodules. Okay, scar formation will be there, and there may be formation of nodules. Okay, now there is progressive destruction of the hepatocytes in hepatic cirrhosis, and tissue undergo fibrosis and shrinkage. So whenever the cirrhosis is taking place, at that time what will happen? There will be tissue undergoing fibrosis, and shrinkage of the tissue will take place. Okay. Now, although many solvents are there, for example, carbon tetrachloride, okay, produce cirrhosis. Okay. Now, the condition is most frequently in the person suffering from chronic alcoholism. Now, in most of the cases, it is seen that person consuming alcohol regularly, okay, is a reason for liver cirrhosis. Now, the fibrous tissue surround the intrahepatic blood vessel and biliary ducts make the liver firm. Okay, so as I said, during the time of cirrhosis, what will happen? The tissue, the liver tissue will become fibrosis, or the fibrosis of the liver tissue will take place. Along with that, the shrinkage of the liver tissue will also take place. So what will happen? The blood vessels, biliary duct which are present around that, if the tissue is shrinking, fibrosis is taking place, at that time that particular area will become firm, okay, and that will obstruct or that will impede the circulation through it. As a result, there will be portal obstruction, portal hypertension. Okay, so like this, whenever the liver cirrhosis is taking place, okay, the portal hypertension takes place. So in liver cirrhosis, first of all, the blood vessels, biliary ducts, okay, because of the fibrous tissue will become firm, and as a result, the blood flow will be reduced from that particular blood vessel. As a result, what will happen? The portal hypertension will take place. Okay, so this is how the liver cirrhosis is causing the portal hypertension. Now, in portal hypertension, what happens? That already we have discussed in portosystemic anastomosis. Okay, so you have to correlate accordingly. Now, here you can see a alcoholic cirrhosis and severely distorted liver parenchyma. So this is also a beautiful CT scan image. Here it is not unenhanced CT scan image. That means contrast media is not given, neither through intravenous route nor through oral route. Okay, after that, without giving the contrast media, CT scan is taken. Okay, so you can see the echo texture of the liver. Okay, so this is a case of alcoholic cirrhosis where the liver tissue is severely distorted. So see here the concentration, or you can say tissue density is different. Here the tissue density is different. Okay, that means the normal parenchyma is not there. That means distorted parenchyma of the liver has taken place. Okay, so this is the appearance in case of alcoholic cirrhosis of the liver. Okay, next is the liver biopsy. Okay, so it is a very commonly done procedure in order to diagnose the problem in the liver, where a small amount of tissue is taken out from the liver, and then the slides are prepared, okay, to do the pathological investigation. Okay, in different types of carcinoma of the liver biopsy is done. Okay, now in order to do the liver biopsy, you know that the needle is inserted. When the liver biopsy is done, at that time needle is inserted into the liver. Okay, and then some tissue is taken, some tissues are taken out from that particular needle to prepare the slide, and that is seen under microscope to know which type of changes has been taken place in the liver tissue. Okay, now in order to insert the slide, in order to insert the needle, okay, you have to know the anatomical landmark, okay, from where you will insert the needle. Okay, so now see, we know that liver is located in the right hypochondriac region where it receives protection from thoracic cage. Okay, so the needle is commonly directed through right 9th intercostal space in the mid-axillary line. Okay, so on the right side, mid-axillary line. Okay, so how to draw the mid-axillary line? From the midpoint of the axilla, you have to draw a straight line vertically downwards. Okay, in the mid-axillary line, that also in 9th intercostal space, that means in between the 9th and 10th ribs, the needle is inserted. Whenever the needle is inserted, you have to ask the patient to stop breathing. Means you have to ask the patient to hold the breath. Okay, because liver is situated just below the diaphragm. So during the time of respiration, it is also moving. Okay, it can cause damage to the other part of the lung. That's why you have to ask the patient to hold the breath when the needle is inserted. Okay, now here you can see the diagram. Okay, see in the 9th intercostal space, that means between the 9th and 10th rib, okay, the needle is inserted, okay, into the liver, and then some amount of tissue can be extracted so that the pathological study can be done. Okay, now here you can see the costodiaphragmatic recess, the needle is passing through the costodiaphragmatic recess. Okay, and then it is going into the liver. Okay, next another important procedure is there which is related to the liver, that is called as TIPS, that is transjugular intrahepatic portosystemic shunt, or also called as TIPS. Transjugular intrahepatic portosystemic shunt. Okay, transjugular means through the internal jugular vein. Okay, so it is a well established percutaneous modality for decreasing the portal hypertension. Means whenever the person is suffering from portal hypertension, at that time this procedure is performed. Okay. Now what is done in this procedure? Mainly the clinical indications for transjugular portosystemic shunt include refractory variceal hemorrhage, means this is a type of hemorrhage of the liver, and refractory ascites, means when these two conditions are there, at that time this particular shunt is done to reduce the portal hypertension. Now in this particular procedure is created by placing a stent between the portal vein and the hepatic vein. Okay, so actually what happens in case of portal hypertension? The blood is unable to flow. Portosystemic anastomosis is there. Okay, through that anastomosis, the blood from the tributaries of the portal vein should go towards the tributaries of the systemic vein. Okay, now in that, if any problem is there, okay, suppose obstruction is there, narrowing is there, compression is there, so many things can be there. So to reduce that particular problem, what is done? A stent is placed. Okay, and the stent is placed between the portal vein, tributary portal vein, and the tributary hepatic vein, so that the blood can flow easily, and that will reduce the portal hypertension. Okay, now resultant shunting of portal venous blood flow to the systemic circulation helps to reduce the portosystemic gradient. Okay, now just see the direction. In severe portal hypertension, a balloon catheter is introduced into the internal jugular vein. From there it will go to the superior vena cava. From there it will go to the inferior vena cava. From inferior vena cava to the hepatic vein and the liver tissue, and through liver tissue it will go to the portal vein. Okay, this is the direction through which the balloon catheter is passing, and through that the stent can be placed. Okay, so as a result, what will happen? The pressure, okay, will be reduced. That means the portal hypertension can be reduced. Now here you can see transjugular intrahepatic portosystemic shunt. So as I said, the direction you can see, and see the stents are placed. Okay. So this is the tributary of portal vein. This is the tributary of IVC. So the stents are placed so that the blood can flow easily without any obstruction. As a result, the pressure will be reduced. Portal hypertension can be reduced. Okay. So that is all about the applied anatomy of liver.